For all your medical supply needs, visit MedSafe Medical Supplies Limited. We offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and so much more. Conveniently located on Gemmett's Lane, just a 2-minute walk from the Queen Elizabeth Hospital. And for your convenience, we deliver free to the QEH. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Call us at 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials. To everyone here with us on Q100.7 FM for what is another edition of the Pulse Radio Show. I'm Shane Seeley, and it's always a pleasure to be with you here on a Monday morning. Sometimes it's sad, and sad for a good reason. This is our grand finale for season 3, but there will be a season 4. So, we're sad to take a break. We have to reflect. We have to look back at some of these discussion points that we've been sharing with you over the past few weeks. Well, more than a few weeks, really, 10 weeks, and going strong. But we need to reflect. We need to, check the messaging and really come back with more that is happening at our hospital, because a lot is really happening at our hospital right now. We have a lot to talk about today, a whole lot to talk about, and as promised, we will be speaking about management of strokes, something that is really affecting our communities, something that is really affecting Barbadians at many levels. And we always have been preaching, especially this season, being proactive in your approach to your health care. This is another step in doing just that. So I have many guests today, one more than usual, I would say, and many of you would have seen our promo or flyer going out across social media, across some traditional media as well this morning on Morning Barbados, speaking about who will be on with us today. So of course we have our Head of Accident and Emergency, Dr. Anne-Marie Cruickshank. She's been spending a lot of episodes with me this season, but for a good cause and for a good reason, to help you to, for one, avoid A&E as much as possible. But the other thing is just to give you that advice that you will need in managing several conditions that she and her teams, her medical teams, see in A&E, see and treat in A&E. Along with her is a newcomer to the show, Dr. Simeona Jacinto. She is head of neurology at the Queen Elizabeth Hospital, and she is one of those who treats and manages those who come into our hospital who would have suffered with strokes. Great to have you on, Dr. Jacinto. And I know this message today will reach not only far and wide, but importantly to those in terms of dealing with this condition in a timely manner and helping to improve their chances of saving a life or having adverse effects coming from strokes. But we could not go out this season without having our Chief Executive Officer back with us. I don't think he spent any time with us this season because he was busy making sure that a lot of those action points from our strategy, our 2025 to 2028 strategy, are starting to take shape, and we're seeing a lot of things happening, and that's where we'll start before we get into the stroke conversation. And I'm pretty sure you'll hear more from him, especially in the next season, as some of these activities that we've been actioning take further shape. So good morning, everyone.
Good morning.
Morning.
Morning, Shane.
Yes, great to have you on. And CEO, sorry to drag you out because I know that you were very busy today, especially you had some other meetings, but I know you wanted to be here to speak about the several activities that you have been spearheading with our executive team and our medical teams at our hospital. So let's get going there. A synopsis of all of these activities that we've been engaging with staff, and that visitors will be the beneficiaries. Visitors, when I say visitors, I mean the patients, will be beneficiaries of.
So thank you for inviting me back, Shane. It's been some time. I think the last time I was here, last season, we were talking about the strategy and how we're going to roll that out over the next 3 years. And I said that I didn't want to come back onto the show until we've started to do something. Because last year was the year of talking, this year is the year of doing. But it's important that we do keep the public up to date, because there's so much happening at the Queen Elizabeth Hospital right now. Sometimes maybe too much is happening. And let me try and give you a little bit of a reminder. We wrote a strategy which we signed off, and we consulted on and signed that off, and we're currently implementing that strategy as we speak. We re-achieved our gold accreditation, and now we're progressing to try and get platinum accreditation. We've introduced something really important, and we'll pick this up today, about policies, a policy on policies. And it sounds quite simple, but if we're not clear what the policy is, then how do we know we're delivering it? And we're going to speak about stroke and stroke policies and stroke protocols. If we're not clear what that protocol is, if every person involved in that patient's journey isn't clear, then how do we know we're going to be delivering it? So we're working with a new platform called Sophia, which allows us to get all our policies into one place, but it also goes further than that. It uses AI to develop pathways and teaching for those who use the policies. And that's something that we're rolling out right now. You've continued, Shane, this great work on the town halls, where with this season has been about educating the public, and what we're trying to do is say the best form of treatment is not to be ill in the first place. The best way to manage a stroke is not to have a stroke in the first place. And it's really important, therefore, that we educate the population how to avoid illnesses, but then also educate them that if something does happen, reassure them and educate them what would happen in the QEH and how we would support them. We've been busy also working on, and that was the meeting you pulled me out of this morning, Shane, on the new clinical governance framework. And that's about how we manage quality in the organisation, how we manage risk and how we manage and improve quality, and also how we engage with patients. And we know that we don't always get it right when we're dealing with the patients, and we see a lot of complaints still coming in relation to maybe we were rude to the patients, or we weren't sympathetic enough. Now, it's a frustration that we brought out at our own town hall earlier this week, and I said, enough is enough of that. 95% of our staff do an excellent job and support their patients really well. A small proportion might not, and it's our job to say that is not acceptable by any means. And if a staff member's not providing support to a patient or a family member, they really have to think about what kind of organisation they're working in and why. And if a staff member is watching somebody be rude to a patient or a family member, they're equally complicit. It's not acceptable. And if a supervisor or a manager doesn't tackle the individuals, that's equally unacceptable. We know that some of the staff get a hard time from some of the patients. That's also equally unacceptable. But as QEH staff, we have to be bigger and stronger, and we won't fight fire with fire. We'll fight fire with compassion, and we will bring the patient back down because they're scared, they're afraid. So we need to support them, and that's really important. All the changes we bring into play is still dependent on how we interact as human beings, no matter what systems we get, IT systems, how we interact as human beings with other human beings. So what's happening in the QEH? You'll know that we've got a full review, and Dr. Cruickshank's here at the moment, a full review of the A&E patient flow. One of our top priorities this year is to sort out these long waits in the A&E. We've done the review of that patient flow, and we're about to start implementing a number of changes. We're bringing in a new electronic bed management system, which will help us track where the patients are in the hospital, and that'll link closely with our new discharge policy, which includes a new estimated date of discharge for us to move the patients through the hospital as efficiently as possible, creating more beds for those patients in the ED to come into the hospital. We've started to develop, and we need to work through with the clinical teams, a bed optimization plan, how best we can manage our beds and where those beds should be and the right numbers and types of beds. A clear escalation plan for the whole of that journey, from A&E to diagnostics to inpatient stays to discharges. A review of our morning daily huddle process, how we how we feed back every day what's happening and how we react to the daily pressures. You'll know we've installed additional diagnostics into the A&E department, and we increased the nurse staffing in the A&E department. We're out to recruitment for additional doctors for the A&E and also for additional doctors within the hospital as a whole. On that digital front, we now have a new internal intranet which communicates internally of what we're doing, and it guides our staff as to what new documents or what new process is in place. We have completed the technical evaluation for the health information system. We're hoping that we'll be able to announce that very shortly. We have initiated the digitisation of the medical records, so when the health information system comes, we can get the medical records directly onto it. We are out to tender for the new HR information system. Currently we have nearly 3,000 staff, 2,800 staff, and we're on paper records. And if I want my HR department to tell me who's done mandatory training, who's done an appraisal, so hard, they've got to search through all those files. The new HR information system will make that much better and much quicker for us to work out where we're up to. We're also out for tender for the teleradiology backlog, to catch up on the backlog of teleradiology readings, which will be a great support not only to A&E but for the inpatients and the outpatients. We're working on the 24/7 workforce project, which always sounds strange because the hospital is open 24 hours a day, 7 days a week, but not everybody's contracts are aligned with that. So we're working with the unions and the staff as to how can we align ourselves to be a true 24/7 workforce in the hospital. You might have seen, if you've been to the QEH website, a new recruitment page. We're trying actively to recruit locally, but also to recruit from overseas in the local region. And we're advertising, the beautiful Barbados is a great place to come live and work. And we do struggle, as most places do, recruiting clinical staff. We've revisited our mandatory training, our absence management policy, our staff engagement plan, and within our staff engagement plan, we've got some good news for the team, that there will be a gym and there will be a nursery for the staff at the QEH as part of the Enmore development. And myself and Shane and a number of others are also keen to explore what we can do with the sports field at the back, to get something down there where we can have the staff coming together to play road tennis, walking, exercising, HIIT classes. So we've got some ideas, some big ideas for what we want to do there, to make sure that the staff can get socially engaged and work together in the hospital during the daytime, but relax together, train together, be healthy together in the evenings. Healthy minds and healthy bodies are what we need in the hospital. You'll be well aware, and we've said this a number of times, we was approved for 293 new staff, and we're busy recruiting those new staff. We had 180 posts which were not previously approved, which is good news for those staff, so they're now on approved posts. We're reviewing our financial systems, a little bit like our HR systems. Some of our financial systems are slow and they don't talk to each other, which makes it difficult to enable payments, timely payments. We're rolling out the new inventory management system. We're doing a full review of all the procurement policies, processes, protocols, and training the staff with an aim of reducing stock out significantly. We've received our first tranche of the 130 million capital expenditures to buy new equipment for the hospital, and we're working diligently through this list of over 450 items of new equipment that we want to bring into play for the hospital. We've got the linear accelerator, the bunker for the linear accelerator, the civil works is completed, and we'll be bringing the linear accelerator into play this year. We're working closely with UNOPS to sort out the Lions Eye Care Centre with new equipment, a new waste management system for the hospital, workforce refurbishments and morgue ventilations. We're progressing with the Maria Holder Foundation for a new rehab centre. We're progressing with detailed plans now for the Enmore site, which will include 5 or 6 floors, including a new oncology centre, a new laboratory, some clinical spaces and all the admin spaces. And as I mentioned before, the gym and the nursery will also be going in there, and a link bridge connecting the Enmore Centre or the Enmore site to the main QEH site. We're also trying to explore how we can get some more car parking, because we was aware when we did the consultation, both staff and the public said one of the big challenges is car parking. So the team is having a look at what the options are for car parking, and we'll come back to that when we've explored some of those options. So there's so much going on in the hospital, but there's also things going on outside the hospital. We're working closely with the Ministry of Health and Wellness on areas where we can work collaboratively. For example, supported discharges out of the hospital, avoiding people having to come to the hospital in the first place. So we continue to work closely with the Ministry of Health and Wellness on improving the whole of the patient journeys. We're having a look and looking at the governance structure of the QEH and how the QEH is funded, and maybe there's better ways of doing that, and we're in early discussions about how we can maybe improve both of those areas. So again, there's so much going on at the QEH at the moment. We've been super busy, but I guess what people really want to see is they want to see it being delivered. And that's where we're aiming to be this year. It's about delivery and it's not about talking. And that's why, Shane, I was trying to avoid being here until I want to say, look, it's done. Here you go. We've got these things in place, finished. Well, we'll have more of those coming through.
We're definitely on track. And of course, by the time we start the next season, later in June going into July, you will hear more about a number of these things taking shape and some of those items being delivered. Of course, this is a process and we want to keep you updated right here on the Pulse Radio Show. We'll take a quick break, but when we come back, we dive straight in to our conversation on stroke.
All your medical supply needs, visit MedSafe Medical Supplies Limited. We offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and so much more. Conveniently located on Gemmetts Lane, just a 2-minute walk from the Queen Elizabeth Hospital. And for your convenience, we deliver free to the QEH. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Call us at 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials.
Pleasant good morning to you again. You're back on the Pulse Radio Show. I'm Shane Seeley, Communications Specialist, alongside our Chief Executive Officer, Neil Clark. You would have heard him deliver that laundry list of items in action, and they're being delivered as we speak. Again, we'll keep you updated on that. But we'll go to that conversation. He mentioned it too, those pathways that we are trying to improve our processes and protocols. And we have to do that for managing stroke. Dr. Cruickshank is here along with Dr. Jacinto. Dr. Cruickshank, our head of A&E. Dr. Jacinto, she's our head of neurology. So let's get into it. And since you're the newcomer, Dr. Jacinto, to the program, but definitely not to the QEH, let's talk about what is a stroke. Let's get into those definitions and let's frame this conversation.
Thank you, Shane, and thank you so much for having me. And, I just want to reiterate the point that the CEO made, that the best way to manage a stroke is to simply not have one in the first place. And, that involves lifestyle changes and lifestyle management. So no smoking, limiting alcohol use, regular checkups with your physician to manage and screen for risk factors such as hypertension, diabetes, and high cholesterol. And stroke is an important cause of morbidity and mortality worldwide. Globally, it's the second most common cause of mortality, and it's the most common cause of morbidity. And those numbers reflect also in the Caribbean and Latin America. In Barbados, the BROS study, which is Barbados Registry of Strokes, found our numbers to be 1.4 strokes per 1,000 persons. That risk increases with age. It also found that 70% of those people had high blood pressure, and 1 in 3 had diabetes. So there's a real role here for management of those risk factors.
And when we talk about signs and symptoms, Dr. Cruickshank, you see them come into the A&E all the time. What are some of the things that people can look for?
Okay, so first of all, the signs and symptoms can be very subtle. So you have to have a high index of suspicion that you may be having a stroke. For example, being confused, just acute confusional state as we call it. Weakness of the face, the arms, the leg on maybe just one side of your body. Difficulty speaking, or what we say slurred speech, or maybe not being able to speak at all. Right? Trouble walking. Right? Dizziness or just loss of balance or coordination. A severe headache can be a stroke. And sometimes I've heard persons say difficulty writing. This is not how they write, so they know something was wrong. So these are signs and symptoms that present to the A&E, and we automatically have to think, is this person having a stroke?
And I know members of the public will have questions in relation to identifying strokes and just about managing the condition in general, what to do. You can call us at 434-1007 or 434-1070. You can also send us a WhatsApp at 434-1007. We want to hear from you. We want to help you understand this condition, because there are some challenges that we are understanding that are out there, especially as far as misconceptions about the condition are concerned. Types of strokes, is there more than one type of stroke? Because as you mentioned, Dr. Cruickshank, it can display itself in various ways. So Dr. Jacinto, is there more than one type, or what do you look at?
Yes, you're absolutely right, Shane. There is more than one type of stroke. And the key thing is they all present in the same way. So a very useful acronym to use is F.A.S.T. F for face, A for arm, S for speech, and T, time to call an ambulance.
Oh.
Okay? And it is all of the signs and symptoms Dr. Cruickshank just went through. Facial weakness, an inability to smile, weakness in the arm or one side of the body, and difficulty speaking. Once you have these, T, time to call an ambulance, 511. The different types of stroke, the most common type is the ischemic stroke, and that happens when a blood clot blocks the flow of blood to the brain. A hemorrhagic stroke happens when a blood vessel bursts and there is bleeding into a brain. There is also something called a TIA, which is a transient ischemic attack, or what some folks call a mini stroke. And this is when the symptoms of stroke do not last very long and they recover within 24 hours. It is very important that if you are having signs of a stroke and they go away, you may think that you're okay, but you must seek urgent medical attention regardless. Because if you have had a TIA or a mini stroke, you are at high risk of progressing to a full-on stroke. So do not delay. You must seek urgent medical attention regardless.
And in seeking that urgent medical attention, Dr. Cruickshank, what is that type of stroke that you would normally see, or are you able to assess that on initial assessment when patients come to accident and emergency with these symptoms?
Well, first of all, it is important, as Dr. Jacinto said, that you present immediately, time to call an ambulance, right? That's important, because the challenges we're finding is that patients are presenting quite late to the A&E, and therefore the stroke that Dr. Jacinto mentioned is ischemic stroke, which is the clot blocking the blood supply to the particular part of the brain. That can be reversed if we get you as soon as possible. Within 3 to 4.5 hours, we can give you clot busters to dissolve or to break up that clot, and therefore to try to resolve the neurological deficit that you are presenting with.
And you talk about time being critical, time being one of the main factors in terms of not only saving your life, but reducing the level of, discomfort or level
Time
of...
is brain, Shane.
Time is brain.
So what timelines are we working with in terms of trying to reduce the effects or the long-term effects of suffering with a stroke?
So as we mentioned, 3 to 4.5 hours is the window we have to work with. So therefore, as soon as you think you are having a stroke, you call the ambulance and come down to the A&E. If you cannot get the ambulance, you have private ambulance. If you have to do private transport, then you have no choice. But the ambulance really is the agent to call to transport you to hospital, because they can start doing things in the field and they can pre-alert the A&E that they're bringing in a stroke, and we can have things ready as soon as you come through the door.
Common misconceptions. Let's look at some of those. What are some of those common misconceptions that can cause some of these challenges that we are seeing in the community with those who live and suffer with strokes?
I think one of the common misconceptions is nothing can be done for strokes. In the old days, the old people would put a nutmeg in your cheek or put the Bible over your head and you've had a Passover, and therefore nothing can be done for you. We've moved away from that now. We can treat strokes and you can have a full life even though you've had a stroke.
You see the look of shock on my face. I can't believe that. That is something that would actually happen. But that's why it's important that we have the education. We also have a stroke unit. Talk a bit about that stroke unit, what it does, and how do we help patients recover from strokes.
So I will talk about that. I just wanted to reiterate something Dr. Cruickshank said, which is that, you know, the earlier you come for the management, especially if you are a candidate for the thrombolysis, the idea behind the thrombolysis is to try and prevent further damage to your brain, and in fact try and recover some of the brain tissue, and so actually improve the deficits, the weakness, the numbness, the speech problems that you're having from the stroke. So that is the level of care that we are talking about now. Okay. So once someone has been admitted to the hospital, it's an entire health care team that's managing them. It's doctors, nurses, therapists, when needed, the social workers, the psychiatrists, also the dietitians. And some of the medications you would get would be ongoing blood thinners, medications to manage your cholesterol, blood pressure, diabetes. Rarely would you need a surgical procedure to release pressure building up inside of your skull and brain. While you're in hospital, you'll be medically stabilized and then get assessments from members of the therapy team. So that is your physiotherapists, speech therapists, occupational therapists. And they all have very key, very important roles that prevent you from getting complications of your stroke, such as aspirating and having a pneumonia, from having falls, and to get you up and moving as soon as possible, and to set what we call your rehabilitation goals.
The Meta Life project is something you spoke about on this program earlier in the season. I remember we had Dr. Brian Charles and spoke about the private sector's collaboration with us at the Queen Elizabeth Hospital to deal with the onset of conditions similar to these. Does our stroke management consist or go through that process as well?
Unfortunately, at this point in time, we have not included the private sector in the management of stroke. I think it's because the timeline is so narrow that if they do present to the private sector, they need to refer them as soon as possible to the A&E, so that we can see if it's an ischemic stroke, i.e. the one with the clot, that we can start the medication to dissolve that clot and reduce the neurological deficits. So that is something to look at, but the Metalize gives us more time because we have 12 hours to play with Metalize.
Right.
With stroke, we only have 3 to 4.5 hours. So you see, we're on a time crunch as the patient presents.
And funny enough, I think that speaks to what you would have said earlier, some of those myths, those old wives' tales that were being said. It would suggest that you have more time than you really think. And for heart attacks, you may even have more time than for a stroke.
Well, yes, but strokes, as Dr. Jacinto said, it's a brain attack, similarly to a heart attack. And I'm going to put a plug in, Shane, for the Heart and Stroke Foundation of
You put your other
Barbados.
hat on
My
now.
other hat.
Right.
My other hat is the medical director of the the emergency cardiac care program at Heart and Stroke, and our aim is to educate the public on both heart and stroke signs and symptoms. And we do have the courses for laypersons and for doctors for those recognitions.
All right, so when we come back, we'll talk a bit more about that public education, how people can receive that readily, because that's what we're all about. As our CEO said, prevention is definitely better than cure. We come in at the QEH when we have to do the cure, and we're very happy to do that. And we have to improve our pathways so that you are satisfied with how you are treated at our hospital. We'll take a quick break. Remember, our program is being brought to you compliments MedSafe Medical Supplies Limited.
For all your medical supply needs, visit MedSafe Medical Supplies Limited. We offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and so much more. Conveniently located on Gemmetts Lane, just a 2-minute walk from the Queen Elizabeth Hospital. And for your convenience, we deliver free to the QEH. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Call us at 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials.
Back with you on the Pulse Radio Show with our CEO Neil Clark, Dr. Anne-Marie Cruickshank, head of A&E, and Dr. Simeona Jacinto. She is the head of neurology at our hospital. I'm Shane Seeley, communications specialist, and very shortly we will be welcoming in our other part of the route to treatment at the Queen Elizabeth Hospital. That would be Dr. Harley Mosley III, to speak about the rehabilitation side of things. What happens after you've suffered that stroke? How do we get you back to some sense of normalcy? Dr. Cruickshank, before we went to break, we were talking about the Heart and Stroke Foundation and the role in public education. Talk about some of those programs which help to educate the public about stroke, about management, and about recovery as well.
Right. So we have our Heart Saver course, which is for public laypersons who are not medically trained, and we therefore train persons in not only medical emergencies but the recognition of strokes and heart attacks.
So like people like myself
Correct.
and Mr. Clark.
Exactly. So persons who are not medically trained will do the Heart Saver. And then we move forward to the BLS and the ACLS, where we have an ACLS for medical practitioners and healthcare providers, the stroke symptoms and the management of stroke more in depth from a medical standpoint. We also have CDPNR, which is our rehabilitation arm of the Heart and Stroke, where the heart attacks and the stroke patients come for rehabilitation. So we continue what Dr. Jacinto and Dr. Mosley are doing in the hospital. We continue at Heart and Stroke. So we provide, as much as we can for education and awareness for the public and for healthcare providers for these patients.
What assistance do you need at the Heart and Stroke Foundation with further developing your programs to reach as many people as possible, especially with the message that could be life-saving?
Well, we need persons to sign up to do the courses because the Heart and Stroke is a non-governmental organization, and we function by persons doing the courses. So that's important. And also for persons who want to become instructors in the emergency cardiac care section of the Heart and Stroke in terms of Heart Saver, BLS, ACLS, and even now PALS, that we're trying to bring back the pediatric aspect at Heart and Stroke. So instructors and persons to support our courses.
Indeed. Dr. Jacinto, in terms of, let's go into that initial part of rehabilitation, because you're involved in that as well. What do we see? I mean, some people after strokes, they may believe that there's no future, there's no getting back to normal. What does life look like, especially after a massive stroke?
Sure, I'm really happy you've asked me that question, Shane, because that's what everyone worries about the most. The patients themselves, their family, their friends, their co-workers. And strokes can affect people in different ways. And for some, it may take days or weeks to have recovery, and there may be little impact on their lives. But for others, recovery can take months or even years, and can mean making life changes. So things like having to adapt to their home to make it easier for them to move around, And some may need to stop working, whether that be temporarily or long term. And the same goes for driving. And your recovery really depends on how much the stroke has affected you, physically and mentally. And when I say mentally, I mean cognitive function, such as ability to concentrate, your memory, your language.
Even motion, your
Yeah.
ability to
Yes.
read, write,
Exactly,
etc.
yes. And also how it affects you emotionally. And that's where the psychology and psychiatry aspect comes in. And so that is why a rehabilitation plan is so important. And that starts from day one, making those assessments and really trying to improve and maintain your quality of life. Persons get a plan with exercises, activities, and therapy sessions as part of the rehabilitation. And they are difficult, but they are important to help you make progress. And like I said, support. So there's support from your healthcare team. So this would include your therapists, so the physiotherapists, occupational therapists, speech therapists, your family physician or an internist, or even your general practitioner, as well as psychologists and psychiatrists for cognitive therapy or other therapies that are needed. And most importantly, persons who've had a stroke always do much better with the strong support of their family and their friends. And carers also need to remember to take care of themselves and find support for themselves as well.
You mentioned the statistics
Yeah.
about just over 1 in 1,000.
Yes.
But are we seeing an increase in the number of people presenting with symptoms and signs or the actual stroke itself?
I think the trends have remained relatively stable. What I can say, just when I was a resident, I did a study on strokes in young adults, and I think I was quite surprised by how much earlier in age people are presenting with stroke. And I think that is one of our biggest worries. And they're presenting with things like hypertension, uncontrolled hypertension at a young age.
And when you say young age, break that down. What are we talking about? 30s?
Yes.
20s?
So young strokes are between the ages of 16 to 45. Yeah, that's what's considered a young stroke. Now, within that age group, the risk does increase with age. But like I said, it's becoming a higher number than we would like to see, I think. And again, that just comes back to the very first thing the CEO said. The best thing to do, the best way to manage a stroke is to not have one in the first place. And it's about lifestyle change and really going from an early age for regular doctor's visits, just to screen for diabetes, hypertension, cholesterol, getting your regular exercise, not smoking, limiting alcohol use.
Absolutely.
Same thing over and over
Absolutely.
again.
And as
Yeah.
Dr. Cruickshank also said, people can do a lifesavers course. So if
Yeah.
somebody does have a stroke or a heart attack or anything else, you can save somebody's life. Now, I've done my lifesavers course, and I feel confident I could save somebody's life. But I wonder whether somebody else could save my life if I needed it. And I encourage everybody who's not done it to have a good think about doing it. And every organisation or workplace should think, who in that organisation or workplace is trained to support the staff within that organisation and workplace. And as Dr. Cruickshank said, the courses are available, you have no excuses.
Yeah, with the Heart and Stroke Foundation, you can definitely get that training. What does it look like? Because I know Dr. Jacinto said it's as simple as seeing the signs too and calling 511. I believe that would be a part of the training. But is there any action required on the trainee, in terms of helping that person outside of the diagnosing, in terms of what you see and calling 511?
I think the most important thing is recognition. That is very, very
Okay.
important. And then reaction, i.e. activating the 511, activating the emergency ambulance service, so that they can now come assess the person. They can do a quick blood sugar, because there are a lot of stroke mimics. I'm sure Dr. Jacinto will mention stroke mimics. Low blood sugar and even high blood sugar can cause thinking that you have a stroke. So it's important to get EAS, Emergency Ambulance Service, in, assess, and transport quickly to the A&E.
Okay, so we'll talk about stroke mimics in a matter of moments. On the phone lines, we have Dr. Harley Mosley III. Of course, he is in charge of a rehab and really plays a major role in doing just that, helping people to get back to some sense of normalcy after suffering with a stroke. Dr. Mosley, good morning. Welcome to the radio show. How are you doing, first of all?
I'm doing pretty okay, thank you.
Yes, good to have you on. Let's talk about that rehab side of things in terms of getting persons after suffering a stroke back to some sense of normalcy. I don't want to talk about fully normal, because that may not always be a reality in many of the cases where persons would have suffered a stroke. But what does that journey look like, if you can talk me through that, Dr. Mosley?
Sure. Thank you very much for having me on. First of all, when a patient is admitted after being timely diagnosed, because remember the first few hours are critical, the rehabilitation is organized by physicians such as myself, a physiatrist, which would include things such as physiotherapy, speech therapy, and occupational therapy. So one of the aspects that first hits most patients that have strokes is we want to improve their mobility and their independence, because regaining strength and coordination is a major goal. So the patient may undergo some physiotherapy up to 2 or 3 times a week, just to make sure that the patient is feeling up to scratch. And as a result of that, we may, at the point of discharge, we may even prescribe some adaptive equipment and gait aids, such as a walker, a cane, or even some unfortunate individuals may require a wheelchair. But strokes are one of those entities that we encounter in medicine that can encompass all things, and holistically we have to look at the patient during their recovery. And during the recovery, they may also have issues with their mental health and emotional health. So depression and anxiety are often common, and we often have to provide some form of psychological support or counseling, whether it is the physicians and the medical team, or the family that needs to do so. Sometimes as well, with patients who have strokes, they may sound funny or have difficulty speaking or understanding what people have to say. And that is a condition known as aphasia. But nonetheless, that's where we have a speech therapist, because the speech therapist will help them to understand as well as to communicate. Because one of the frustrating things as a stroke patient, and what sometimes can make them more depressed, is when they cannot say what they want to say. Simple things like, I am hungry, or I am thirsty, or I want to go to the bathroom now become monumental tasks to somebody who's had their speech and speech understanding that are altered by a stroke.
So
then, of course, sorry.
No, I was going to add, so there is definitely life after having even a massive stroke. And I really wanted you to speak to, you spoke to the journey of recovery, but to the possibilities of a full recovery having suffered something like that. And then in terms of, we would have mentioned on the show today and a number of times, with that change in lifestyle, if you can reduce your chance of having another such event.
Well, I'm so glad to hear that you mentioned lifestyle changes, because that was, of course, I'm certain that you would have discussed the dietary changes, the quitting the smoking, and managing blood pressure and taking your medications. Am I wrong there, Mr. C?
Not at all. Not at all. We have tackled that today and and many days right here at the Pulse Radio Show, because we want people to do the right thing and understand that they're responsible for their health. Yes, we have a role to play in helping to save lives, but the journey starts with the individual, And that is something we continue to preach right here on the Pulse Radio Show.
Okay. Well, I'm going to differ slightly from you, Mr. Seeley, and not that I'm a naturally controversial person, as those people who know me, but I think the journey with the stroke we come to the team, and once we have finished with the hospital part of it, the family and the family intervention becomes even more important with regards to the team and helping an individual recover from stroke. So it's not only the individual as well, but for families now, families have to provide emotional support, and they have to be very patient, and they have to encourage people, persons who have survived the stroke by, celebrating small improvements and getting them to stay motivated. We also have to make sure that the home, when they go home, that you make special home adjustments, such as home safety modifications, such as grab bars and ramps, might be needed depending on how bad the stroke they have. And simplifying daily routines can also reduce frustration, such as helping them or assisting them to put on clothes, helping them from the bath, from a shower right now to putting on clothes, to even preparing a meal and clearing up after a meal. These are things that we take for granted, yourself and myself, being relatively able-bodied. But when you have a stroke, it is a very debilitating condition. And one of the other things that you learn about stroke and stroke recovery is that the more educated families and caregivers become, the more comfortable they become, and they're more likely to take the patient home rather than, in some cases, leaving them in the hospital and hoping for long-term care. And lastly, you were talking about the patient, but you also must remember that the caregiver or caregivers must remember that they can become exhausted, and they need support to help themselves as well, so that they can continue to take care of their loved one who's had a stroke. So that's it in a nutshell, as you can tell. Most of these are not known for talking very short, but yes, sir. I hope I answered some of your questions.
You definitely did, and we really have a much clearer picture on the recovery, that process to getting back to some sense of normalcy in your life after suffering what can be for many a life-changing event. But change is the one thing that is constant, and it is change that we need to help our listeners, our patients, and the general public to adopt, to avoid such situations, and then in the event that they've indeed suffered from a stroke, really to have that change in their lifestyles to run a better path going forward thereafter. Dr. Mosley, always great talking to you. Thank you so much. We'll definitely share more as we get into the next season of the Pulse Radio Show, because this is a topic that must be in the minds of the public, at the forefront of their minds, for sure. But thank you again, Dr. Mosley.
Well, thank you very much for having me.
I appreciate your time. I know you are very busy, hard to get you away from your clinical work, but I appreciate it nevertheless.
Yes, sir. Thank you.
So, I mean, Dr. Mosley really put it nicely there in a nutshell in terms of what recovery looks like, rehabilitation looks like after living with a stroke. Going forward, as we really look to the future and helping Barbadians better manage things like this, which could be so life-changing, what else do they need to know? What are some of the key things that they need to consider to keep away from this, as Mr. Clark said, to stay away from a life that can really lead to such an event?
Well, I think the preventative measures that we've mentioned already, and then also, if you are diagnosed with a risk factor, especially hypertension, because hypertension, we know the moniker silent killer. So many times we see patients who come in, and because you don't feel your hypertension until it gives you a stroke or a heart attack. And so really managing that, I think, making sure you have a monitor at home, you check your blood pressures. If you're prescribed medications, you continue taking it. It's not meant to be just short term for a month or 3 months, and then once it's better, you stop. It's better because you were taking the medication. Yes, diet and exercise does help your blood pressure. Absolutely. And you must do those things. But, you know, sometimes, especially as you get older, you reach a point where you must do those things, but you need some pharmacological help to keep that blood pressure down. Also, when you, I just wanted to highlight, if someone has had a mini stroke or TIA, or even a full-on stroke but mild, that does increase your risk of stroke. Any cardiovascular event you had, such as a heart attack, that also increases your risk. So making sure that you stay on the prophylactic medications.
Now we have a question coming in on WhatsApp.
Mm-hmm.
If you have a cardiovascular event, does that mean that you'll be on medication for the rest of your life?
Mm-hmm.
Is it a life sentence to the meds?
Well, I don't like to think of it as a life sentence. I like to think of it as something fortunate that we live in an era where we have all these medications. I mean, just a few decades ago, management of stroke was maybe, and heart attack was maybe aspirin and some morphine. But yes, you should remain on some sort of blood thinner or antiplatelet therapy, whether that be aspirin or Plavix. Those are the common ones used here. Also, a cholesterol medication known as a statin.
It's a simple way, isn't it, of staying alive?
Yes.
And it surprises me how many people think it's a death sentence, that I've got to take tablets now forever.
Right.
It's not hard taking a tablet. It's
Yeah.
not hard. It keeps you alive. And I just wonder if you could also maybe emphasise for the listeners that those people who haven't seen a doctor for some time, because they're healthy and they're well and they have no symptoms, the importance of still going to see a doctor even when you're well, just to have your checkups. Because as you say, you don't know that your blood pressure's up until you know.
Yeah.
You don't feel it. It's not there nagging away at you.
Right.
But if you don't go and do these regular checkups with your primary care doctors, then you can find out your risk factors. And it's really important that people do that.
And I do want to give a particular shout out to the men, because women just naturally end up seeking health care earlier because of pregnancies and different sort of female health issues, whereas men don't really have those reasons to. And they have their own reasons for hesitancy for seeking medical attention. So I would really urge men and the women in their lives to encourage the men in their lives to start going for those health checkups early. And when I say early, I mean even in your mid-20s, 30s. You know, you don't want to be discovering in your mid-40s that you now have uncontrolled hypertension.
It's strange, isn't it, how people think that the doctor's there for when they're ill.
Right.
And really, the primary care doctor's there for when you're not ill.
Exactly.
The hospital's there for when you're ill.
That's
We
right.
will treat you because you're ill. But
Yeah.
use your primary healthcare doctors when you're well to stay well.
Right, correct.
Indeed. I gotta big up the nurses. I would be very wrong not to do that today. Today is International Nurses Day, and this is actually Nurses Week. It started yesterday, and there was a church service. Huge shout out to the Barbados Nurses Association, and of course our nurses at the Queen Elizabeth Hospital. They make up the biggest cohort of nurses in Barbados. So, and they're doing tremendous work on the wards, in the accident and emergency department. I know this morning, CEO, they were deploying some beds.
Yes.
Some more beds. We got 50 new beds.
50 new beds arrived at the hospital, currently being fitted up and fixed out to move out to the ward. Some of the beds on the wards are quite old and broken and needed replacing, so we've got 50 new beds. But hopefully it will create also a little bit of additional capacity for A&E, who we know is being particularly busy again over the weekend. So hopefully it will give some respite, and we can move some of those patients up into the additional spaces that we'll create with those beds.
And that's why sometimes I feel a little bad for tearing away Dr. Cruickshank from the accident and emergency, which is so busy most of the time. We're trying to get it right.
But we're trying to stop people coming to the A&E, and it's
Yes.
exactly where we want to. Prevent it, don't treat it.
Yeah, there's a clarification that needs to be made on that admissions. We did it last week with Dr. Corbin Hart, where we spoke about what it looks like when you're admitted to the QEH. And I think people still have that notion that you're only admitted once you have been warded, when you're on the ward. But really, in many cases, from the time you start to get that assessment and treatment in A&E, that's where the admission starts. Correct, Dr. Cruickshank?
Yes, so from the time you come in the door of the A&E, your treatment is starting, you're seeing the doctor, you're getting investigations, management, and then you refer to the specialties, and they come down and they make their assessment if they need to admit you or not. And there are times, presently, where we don't have the beds on the ward. So you're housed in the A&E, but you're being managed by your specialist team.
Yes. So I know that, well, I would hope that would provide some clarity for patients who sometimes believe that they're in the accident and emergency department for an extraordinary period of time, a day or more, but you're actually already temporarily warded in the A&E receiving treatment until you take your next path of your treatment journey. So that is just a clarification that needs to be made. So sorry to say this is the last episode for this season, but we will be back. We will be back in late June, early July. We will announce that date, and we will share it definitely on our platforms, on our www.qehconnect.com. Remember, you can find us there, and just some additional information about our blood collecting center. It remains open. It's at Gemmett's Lane. It's in Gemmett's Lane. I know some people were still thinking that we were at the annex. That was only a temporary relocation. We're back at Gemmett's Lane. But I just want to get those final thoughts from all of you as we wrap up what is the season finale for the Pulse radio show. Dr. Jacinto, good that you could come in to speak about the management of strokes. Your final thoughts for Barbadians and those listeners here today.
Right. Thank you again, Shane, for the opportunity. I think my main takeaway message is the best management of a stroke is not to have one, and you must recognize if you are having one fast. Face, arm, speech. Time to call an ambulance immediately.
Face, arm, speech. Time to call an ambulance immediately. We'll put that on our social media as well so that people can see the signs and the symptoms. Remember, we are also on Instagram and Facebook as well. Dr. Cruickshank, you've spent a lot of time with us this season. You'll get back to work for a few weeks, but then I'm sure you'll be back here with me yet again. Yes. Your final thoughts.
I want to leave the 8 Ds of stroke management.
The
8 Ds of stroke management, which is detection, rapid recognition of these, dispatch, calling emergency ambulance service, delivery, transporting you as soon as possible to the A&E, door, getting you to the door of the A&E, data, getting your CAT scan done so we can see what type of stroke you have. Decision, speaking to Dr. Jacinto, deciding if we have to use the thrombolytics, which is the next D drug, and then disposition, getting you to the stroke unit for Dr. Jacinto and her team to manage.
I know I can't remember those 8 Ds off the top of my head.
You stay with face.
Yeah, fast.
Fast.
I will definitely put that as well on our social media so that you can see. You need to see these things, and please save them as well. Mr. Clark.
I'd just like to say thank you to our clinical experts providing all the advice for you to stay healthy, and thank you, Shane, for bringing us here to share this information with the public.
Yes, I always appreciate having you here, Mr. Clark, supporting us all, the executive team, the medical teams, the ancillary staff, as we try to deliver better care at our hospital, the Queen Elizabeth Hospital. Really want to thank CBC and the Q100.7 team for facilitating us for yet another season. We will be back spending more time here on the radio show, and we got something very special coming called, I think I'll leave that and do some separate adverts for that, but something very, very special is coming from the QEH yet again. Testimonials. Look out for it. That's it. On behalf of Dr. Anne-Marie Cruickshank, Dr. Simeona Jacinto, Mr. Neil Clark, I'm Shane Seeley, signing off for another season of the Pulse Radio Show. See you in a couple months' time.
The QEH Pulse Radio Show brought to you with the kind compliments of MedSafe Medical Supplies.
For all your medical supply needs, visit MedSafe Medical Supplies Limited. We offer a wide range of products including wheelchairs, walkers, canes, crutches, blood pressure machines, stethoscopes, and so much more. Conveniently located on Gemmett's Lane, just a 2-minute walk from the Queen Elizabeth Hospital. And for your convenience, we deliver free to the QEH. Open Monday to Saturday, 8:30 a.m. to 5:30 p.m. Call us at 624-7542. MedSafe Medical Supplies Limited, your trusted source for medical essentials.